Hi, my name is Kayla Fletcher, and I'm a fourth-year medical student at Midwestern University, and I'll be presenting a case on acute tubular necrosis due to minimal change disease in an adult. Just a little background, minimal change disease is the most common cause of nephrotic syndrome in children, but represents only about 10% of that in adults. Common presenting features include volume depletion, generalized edema, but in adults over 60 years of age, hypertension and just an incidental finding of impaired renal function are also common presentations. So laboratory workup typically reveals a low serum protein and albumin and nephrotic range proteinuria, which is greater than 3.5 milligrams of protein per gram of creatinine found in the urine. And hyperlipidemia, hemoconcentration, and hypercoagulability are also commonly associated with this syndrome. Now, it's important to obtain a biopsy on these patients to determine the underlying cause, and in minimal change disease, patients will have complete podocyte foot process effacement without really having changes on light microscopy or immunofluorescence. Most cases of minimal change disease are idiopathic, although secondary cases have been associated with atopy, drugs, infections, and malignancies, specifically hematologic malignancies. Now, our patient specifically was a 56-year-old male with a history of asthma and mast cell activation syndrome who presented to our emergency department with worsening bilateral leg swelling, which had been going on for the past 10 days. He said that he first went to his PCP for this complaint, where he was found to be in renal failure and thus referred to the ED for further evaluation. At this time, he also reported abdominal distension, bilateral flank pain, and foamy urine. He denied any shortness of breath, chest pain, dysuria, or hematuria. And he'd had no prior history of kidney disease or family history of kidney disease. This patient had been to our hospital about 7 months prior, and so we did have a baseline creatinine for him of 0.93. So his physical exam was significant for a blood pressure of 173 over 106. He did have a heart rate that was 102, just slightly tachycardic. His temperature was 37.4, respiratory rate 18, and O2 sat was 95% on room air. With examination of his extremities, he had generalized edema, but specifically 1+ pitting edema of his bilateral ankles. He had no CVA tenderness, and the remainder of his exam was within normal limits. So we obtained a BMP on this patient, which was consistent with an acute kidney injury with metabolic acidosis. He was found to have a creatinine of 3.75, an albumin of 2, a CO2 of 19, and a GFR down to 17. He also had hyperlipidemia when we obtained a cholesterol panel. And in figure 2, you can see his urine studies. Urinalysis revealed that he had greater than 500 protein, so we quantified this with a protein to creatinine ratio and determined that he had 17 grams of protein in his urine. So further workup at this point was negative, including ANA, ANCA, HIV, hepatitis. SPEP and UPEP were also within normal limits. Complement levels were normal, and we did obtain a renal ultrasound, which was unremarkable. So at this point, we diagnosed our patient with an acute kidney injury with metabolic acidosis. We admitted him to the hospital so that we could obtain a renal biopsy. And we also gave him albumin and furosemide in the hospital and then discharged him to follow up in clinic pending biopsy results. So we discharged him with furosemide 20 milligrams BID, sodium bicarbonate 650 milligrams BID, and spironolactone 25 milligrams BID, or daily, and atorvastatin 40 milligrams daily. So when we obtained his renal biopsy, you can see in figure 3, this is a picture of his electron microscopy. And he did have complete podocyte foot effacement, which is seen with minimal change disease. In figure 4, you can see the light microscopy that we obtained from this patient, and he essentially only had slight changes of acute tubular injury, but you can see that he has some protein casts stuck in his tubules, especially on the right side there. And he had no glomerulosclerosis and no immune complexes seen on immunofluorescence. So when this patient followed up in clinic a few days later, we decided to start him on prednisone 80 milligrams daily. with intent to use for the next 8 weeks, and we increased his sodium bicarb to 1300 BID. And because he was on the steroids, we also decided to give him prophylaxis for PCP with some Bactrim, and we gave him fluconazole for cocci prophylaxis. So we then had him follow up in clinic 6 weeks later, and at that point he had significant improvement in his edema. He had lost 40 pounds of water weight, and on repeat labs his creatinine was 1.4, his GFR was down to 52, his CO2 had normalized, and his protein in the urine was only 540 milligrams per gram. So we did lower his prednisone at that time to a taper dose of 10 milligrams daily. So just a little bit to discuss about this patient. In a patient who presents with nephrotic range proteinuria, in addition to minimal change disease, especially in adults, the classic differentials that you would consider include FSGS, a membranous nephropathy, diabetic nephropathy, and amyloidosis. So it's really critical in these patients to obtain a renal biopsy in order to determine the underlying cause. And in minimal change disease, like I said, you'll see the podocyte foot effacement without really changes on light microscopy or immunofluorescence. It's important to note that because biopsies are only taken from a few nephrons, it is possible to miss the sclerotic changes that are seen in focal segmental glomerulosclerosis. So it's possible to misdiagnose a patient with minimal change when they actually have FSGS. Now, acute kidney injuries are actually a common complication of minimal change disease. Commonly on biopsy, you'll see acute tubular injury, edema, or inflammation. And there have been many studies about this. It's not entirely understood, but many hypotheses have been proposed for the correlation between minimal change disease and AKIs. And these are related to volume depletion, the tubules being obstructed from interstitial edema, or by changes in cytokine expression. For example, one study suggested that the mechanism may be related to when high levels of albumin and transferrin are in the proximal tubule. This can increase tubular cytokine expression, including fibronectin and the chemoattractants PDGF and MCP1, which leads to inflammation and scarring of the nephron. Other hypotheses include that high levels of protein overwhelm the ability for the lysosomes to degrade them in the proximal tubule, and this leads to increased endoplasmic reticulum stress, leading to high levels of reactive oxygen species, which can activate the complement cascade and induce apoptosis. So these mechanisms may all be part of what contributes to the development of chronic renal failure in these patients with minimal change disease. Now, a little bit about treatment. Corticosteroids are well known to be the mainstay of treatment for minimal change in children, but there have not been a lot of studies in adults to show that this is effective at inducing remission. Despite this, the Kidney Disease Improving Global Outcomes guidelines continue to recommend high use of high doses of prednisone or prednisolone at a dose of 1 milligram per kilogram, up to 80 milligrams a day for 4 to 16 weeks in order to achieve remission. And then they suggest that you use a taper as well for up to 6 months. Now, there have been many studies to assess if this is actually effective, some saying that the median time to remission can be 1 to 2 months, although some saying that approximately 1/4 of patients never actually achieve remission. And in those that do, relapses are very common in more than half of patients, and 1/3 of those patients who are treated actually become frequently relapsing, which means that they have more than 4 relapses per year, or they become dependent on steroids such that it's not effective. So at this point, in these cases, KDIGO recommends that we trial cyclophosphamide, cyclosporin, or CellCept as a treatment instead of steroids. So it's important to treat these patients because untreated minimal change disease can lead to significant morbidity and mortality due to hypoalbuminemia, and they also have accelerated atherosclerosis. They can have thrombotic events from the hypercoagulability of leaking clotting factors, and they also have increased risk of infection. And that is all. Thank you.